Libin Cardiovascular Institute, Department of Cardiac Sciences, Division of Cardiology, Grand Rounds. I'm Todd Anderson, for those of you who don't know me, and I am a cardiologist still, and have the privilege of being the Dean of the Cummings School of Medicine. We have a very special rounds today, but before we do that, I'd like to start us off in a good way by acknowledging that we are at the University of Calgary on the traditional lands of the people of Treaty 7. That includes the Blackfoot Confederacy, the Tsuut'ina First Nation, and the Stoney Nakoda. And Calgary is also home to Métis Nation of Alberta Districts 5 and 6. And we have the privilege of working and thriving and playing on these lands. So we're very pleased today to introduce Dr. Daniel Lackland from the University of South Carolina. Dan is a professor in the departments of epidemiology and neurology, and really is a leading research and educational star in the area of cardiovascular prevention. And he's here today, as you'll see during the rounds, to present a very special award, the Graham MacGregor Award from the World Hypertension League to Dr. Norm Campbell. And this is about efforts of salt reduction to reduce the cardiovascular burden of heart attack and stroke. Dr. Norm Campbell is also going to speak. Norman is well known to many of you. He's quasi-retired, but he is a professor emeritus, general internist, been at the University of Calgary for decades, and really a world leader in the area of salt reduction, a passionate researcher and educator and clinician who has spent his life trying to reduce cardiovascular risk through efforts at education and research and policy for decreasing the amount of salt that we take into our diet. And he's made an incredible difference and is a wonderful recipient of this award, as you'll hear from Dr. Lackland moving forward. So please sit back and enjoy these great rounds. And I think at this stage, I would call Dr. Lackland up, and he's going to kick things off, and he'll tell us about the award going through. Norman, congratulations.
Good. Thank you. It really is a great pleasure to be here, and greetings, and kind of move through a few items that we can talk about a little bit about South Carolina and in the, let's see, and in the, this is what I was going to do, implications of hypertension control in southeastern United States. I imagine some of you have been in the southeast, maybe some of you have been to Charleston and everything else. They always come by and say, hey, it's a vacation spot, but it's kind of where I live. And it's known for some other things besides a good place to kind of go. Disclosure-wise, there they are. Don't have any financial disclosures. Strangely, I'd like to start with Joseph Goldenberger and looking at pellagra. And I don't know if you do very much with pellagra, if you've even heard of it in many of the places right now. In Charleston, this is in South Carolina, 100 years ago, this is what we used to see. And this was the #1 thing that was on the curriculum, pellagra. This is what you saw. This is what the direction is going to be. And here is a map, and you can see South Carolina, for those with the geography, the really dark areas, that was South Carolina. This was a really true epidemic in 1930, wiping it out. If you were at the Medical University of South Carolina and you were in the course, you spent most of your time not on anatomy, not on heart disease, not on stroke, where you probably should have been. You fitted on pellagra, because this is what you were going to see for the people that were in Charleston. A little reminder of pellagra, and this is the part where I'm coming from with being in neurology. It was also referred to as the 4 Ds, dermatitis, diarrhea, dementia, and death. And then here in 1912, state of South Carolina reported 30,000 cases of it with a 40% mortality. Just really tremendous, big type effect. You're saying, I thought this was supposed to be about hypertension, and we're going to kind of get there and kind of show it. As a reminder, it's known for a long time that pellagra was associated with vitamin deficiency. They knew that. They knew that. But you wanted to know, what could you do to prevent it? You know why you had it, so you would just kind of pat somebody on the back and say, you got a 40% chance of dying now. What do you do? And this is where it kind of builds in. What we did in South Carolina is taking the data, you recognize that it was niacin. You wanted to put niacin back into the diet. and fortified the fruits, the foods that we're giving into this. In South Carolina, I don't know how it is, in school lunch, right now, you always have a meat in your school lunch program. You don't know what the meat is, but you always have one right there. So you got all of that kind of stuff. And the reason was because of pellagra. We were so excited about it. It wiped it out. It wiped it out now. We don't even introduce it into our curriculum anymore because you don't see it. It's gone completely. And the point of it is there's a success story that you're doing, that you're wiping out a disease. And so we feel kind of that might be the direction that we have. Well, here is, this is another slide. This isn't from the 1950s, and this was put together by the U.S. Geology Society. They went county by county and were looking at stroke rates. Reason being is that Franklin Roosevelt said, I have polio or whatever he had. I have all these other diseases, and my health is not bad. I like to smoke cigarettes, everything else there. But when I go to Warm Springs, Georgia, something in the water makes me feel great, makes me feel 30, 40 years younger. He never said it. He had a girlfriend in Warm Springs, Georgia, and that was probably what was really doing it. But the U.S. Geology said, oh, there must be a water source. There must be a fountain of youth somewhere that we can go. So they went county by county. They never found it. They never found it. Certainly didn't find it in Warm Springs, Georgia. But what they did find was what was referred to at that time, the enigma of the Southeast, was this contiguous group of counties, the North Carolina, Virginia line carrying through southeastern South Carolina and southeastern Georgia, with some of the highest stroke rates in the world, and stroke rates that were happening all over. So this is what you see. You look at the stroke rates. This is some of you have heard the stroke belt. We live the stroke belt. We are the buckle of the stroke belt. This is that piece. So we look now, 100 years later, we still have that type of mortality. We still have that type of piece. That there's something about the geology that we see about being in the southeastern portion of the United States and looking at stroke mortality. So we did a little bit of a work here looking at nativity, not the Christmas side of it, but where were you born? So you live in the southeastern portion of the United States, but where were you born? Does it make much of a difference? Does it make much of a difference, this piece that we have? Is this a population that we need to really kind of focus in on? So we did a little simple thing. People that died of a stroke, you were born in the Southeast or you weren't born in the Southeast. Looks like something like this. I was born in the Southeast, and so my risk of having a stroke and dying is better than y'all's, unless y'all were born with me down in the Southeast. Doesn't matter there. The piece, though, to look at is this one over here. You guys that don't live in the Southeast and you come and you live in South Carolina, your risk is less, nearly 50% less of having a stroke and dying. Amazing. It's all that kind of building into that piece. Doing a little bit of other work, looking at now dementia and looking at some other pieces, that same type of protection that seems to be present for those people not born in the Southeast. It's even greater for African Americans, nearly 50% less risk for an African American, not born in the Southeast. So working with us, we took it one step further, and I'm kind of going somewhere, and don't have to read all of these types of slides. So it can't just be born. That means we ought to come up here to Calgary and deliver your baby here and then come on back. And so it's not being born, right? It's something else. So a little bit of work like this, we looked at what was the duration, what was the exposure to the Southeast during your life that you have it. The big kicker was the 0 to 20 mark right there. Your formidable years, how you live, how you life, and we're going somewhere with this kind of stuff, the lifestyle that you build up between that 0 and 20. I was doing some work with some radio folks, and this radio engineer said, "Oh God, everybody knows that." And I think, God, this guy's amazing. It took me 30 years to learn it, and he learned it. He's already got it. He said, "No, that's the 20 rule." He said, "The music you listen to at 20 is the music you listen to at 70, right, Norm? That's it. You go all the way through. That's why you have the 70 station for people like me and Norm, because that's what we're going to listen to. You know, children hate it, but no, we love it because that's what we want to hear. It's a 20 rule. The food I liked when I was 20 years old, I still like today. Probably shouldn't eat it, and I don't, but I like it. I want it. If you gave it to me, I would love it. It would be great. It's that 0 to 20, the formidable years where we acquire our behaviors and everything else. And that seemed to be what was relating to the piece. And this was for everybody in the population. It's just that 0 to 20. That kind of brings it into that piece. So we looked at it and say, what else is playing a role in here? So you have your health habits, this piece, and I know that y'all know all of this type of work, but kind of looking at this paper we put together, looking at what was the major influences, what can you do to do the best for stroke in a population that has a great high risk? Of course, we're all biased. That's what this is all about. It's hypertension. This is our piece that we thought that was building the great work. So what you want to do is what? Lower blood pressure. So again, let's work towards a success story. Have we done that? Have we managed to do this? This is some looking at the work in 1960s, the blood pressure levels in 1960 in the United States, and then up into looking at basically 40 years later, 50 years later. In every group, every age group, we have done successful. So here, 18 to 29-year-olds, we're not treating them right. But their blood pressure, their systolic blood pressures came down 6 millimeters, 11 millimeters of mercury, making great progress. Doing that with lifestyle. 30 to 59-year-olds is probably a little bit of a mixture. And we get to the big group, the 60 to 74-year-olds. Look at where we've gone. 1960, we've gone from an average systolic blood pressure of 148 down to 129. And you're looking at these other components that we see. If we look at the upper percentile, at one time in the United States, it was in 1960, the average systolic or 90th percentile blood pressure was 188. That's a stroke clearly waiting to happen. Now that's come down to 156, something that we're able to turn around and look about and manage. So again, success story, we've done this. This is a recent paper we did looking at the 40-year shift in blood pressures, with the idea that for every millimeter of mercury that you reduce blood pressure, you lower the risk in particularly of a stroke, heart failure, whatever else that you would want to see, all kinds of built-in. So our work was a couple of things to show with this one particular figure that kind of in this piece. The dotted line is where we are in today, or where we are 40 years later. Look at the distribution, though, in the solid lines for both whites and blacks. You were going out, and if you looked in this particular case, in 1960, which is part of another one of our cohorts, called the Charleston Heart Study and Evans County Heart Study, our Black Pooling Project, we basically had 10% of the population had systolic blood pressures of greater than 200. That's a hypertension emergency. That's where you're really going to do it. 10% of the population had that. The good point that we see here is now look, 40 years later, there's nobody that has systolic blood pressures of greater than 200. That's a tremendous success story. Tremendous, tremendous success story that we started doing it. We haven't got where we need to be. Still have hypertension, still have elevated blood pressure, still have uncontrolled blood pressures, all of those things. But we've almost eliminated those very, very severe hypertension emergencies. I know you guys are in the emergency room. I know you see them, and they are there. But it's not a major piece of the population that we see. And then this other piece that we have is that the impact was better for African American men and women. The impact, the lowering of the blood pressure was much better for that group, and that was with a targeted type of a blood pressure. So we feel like there's some good strategies that maybe we can do similar to what we saw with pellagra. Wouldn't it be great one day to wipe out and eliminate high blood pressure? We could do an awful lot of things. Is this at all possible? One component of that, just like with pellagra, it was niacin. With blood pressure, some of us think it might be salt. And I'll give you my bias, but it's also going to be Dr. Campbell's bias. There's an awful lot of argument about how much salt. You got to have salt to live. Okay, we'll go with that. And there's an argument. Is it 2,000 milligrams? Is it 1,800 milligrams? Is it 2,300 milligrams? Some of us say it doesn't matter. We're all eating way, 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 way too much salt. We're having way too much salt that goes into this capacity. And we're moving into a campaign. And this is where we get it, and I think you all have seen this over and again. You bring it in. We get most of this from processed foods, from restaurant foods, where you're not looking in there. Now I'm going to come back to the Southern diet, Southeastern diet. Maybe it's playing a bit of a role. This is a seafood platter that you would get from Charleston. I took this picture and looked at it. Now, I would tell you, I'm eating seafood. Some of you cardiology and neurology, y'all be real proud of me. You say, oh, that's pretty good. You're eating seafood. Okay, that's really good. Okay, we'll do whatever. And I'm even having a little bit of side piece, a little salad right up in here too. And I'm getting this, but I've got this. Here is my much better than my daily quota of sodium. But what did I tell you? I go eat a seafood platter, and you're telling me I'm doing really good. It's really happy, knowing what that value is, and just a little bit more fun for the Southern diet. And I know y'all have different Costco up here probably and everything else. But if I come to you and I tell you about my diet and I say, listen, you wanted me to eat a Caesar salad. I eat a Caesar salad from Costco. And I do this with medical students and residents and things like this too. So I say, how much sodium's in there? You tell me I'm doing good. How much sodium is in there? And excuse me, let me see. There it is. Okay, 2,600 minutes. But you're not thinking that, are you? You're thinking, oh, he's eating a salad. That must be pretty good. If his blood pressure's still high, I think I'm going to need to give him another pill. And either kind of doing it and bringing it in, because I'm not reporting to you accurately because I don't know. And you probably don't know either. Here's everybody's favorite, P.F. Chang's, that you have it in here. Doctor, I only eat P.F. Chang's once a week, but I really do like it. It's good, simple food, kind of moving it through. And if I look at this P.F. Chang's meal, I'm really looking at 7,900 milligrams that might be fixing it. So some of you say, why can't you read the label? And that's a good piece. And this is that part that we have. So this is a chicken pot pie. I will tell you, I like chicken pot pies. I probably ate them when I was 20 years old, and I still do. So if I'm looking at this, I'm telling you, here's my chicken pot pie. Put it in the oven. It came out. I've got it. And now I'm going to be kind of looking at it. And I'm looking over here, and I'm saying my sodium, 970 milligrams. That's pretty good, right? That's all right. I can eat that. What I failed to look at is they claim that this is 3 servings. Well, not for me. This is 1 serving. I put the chicken pot pie in the oven and I turned around and ate it. But instead of me now telling you I eat a chicken pot pie 970 milligrams, I should be telling you I'm right at 2,800 milligrams. With that, do that. And so the label does good. It's kind of there, but we kind of a piece that we have a place to go, which is why I'm kind of here today. And Graham MacGregor, for some of you that don't know, is a world expert on salt reduction. And probably one of the major pieces that he's done is he recognized where we get salt from. And we can argue with people and go through it. But what he chose to do was to work with industry to reduce the salt, show the industry they could make a profit, they could continue on and build that forward to it. So we have this, the Graham MacGregor Excellence Award in Dietary Salt Reduction at the population level. That's why I'm so excited to be here. Wanted to come up here, present this with my friend and colleague, Norm Campbell, who epitomizes that type of piece. And this is some of the places that we've worked on from a global standpoint, all focused in on building in this part with looking at sodium reduction. So I think that this is a key piece. This is what the World Hypertension League says is the strategy that we can implement in order to reduce risk and reduce blood pressure control. So Norm, I'm going to let you take it the rest of the way home.
Thanks so much, Dan. In about 2006, I had just received a chair for hypertension prevention and control in Canada, and it mandated that part of it would be to reduce the prevalence of hypertension. And at the time, as I looked through the evidence, the best evidence was for reducing population sodium intake. And I was wondering, how would one go about this? And so I looked up Graham MacGregor out of the blue and asked if I could visit him. And so he's really the leader for global salt reduction. And I've been one of his disciples and have done my very best to try to emulate some of the things that he has done. Now, Dan's a great friend of mine, but I'm going to have to vehemently disagree with him on one thing. I can't speak to what 70-year-olds like in music. I have 6 months to go. And so in 6 months from now, I'll try to validate Dan's understanding of what 70-year-olds might like in music. I always had a short attention span, and many of my colleagues do as well, by the way. And so what I thought I would do today was to have 3 very short talks on different things that I've been interested in, and one of them, dietary sodium, one, hypertension control. And as I retired, I became very distraught because I love the high alpine, and it was smoky. And I've never been smoky before. We had a cabin that was flooded. In fact, the whole resort disappeared in a catastrophic flooding of 2013. And so I thought I needed to dedicate some of my time to the Alberta environment. And so if I get time, I'll talk to that. This is probably the last talk of my career. This is the first live talk I've given in 5 years. The other ones have been taped and sent because I no longer travel very much. But I'm going to start with something called the Global Burden of Disease Study, which tries to indicate what the main risks and causes of death are globally. And this is the most recent data. It's from 2021 data on the leading risks for death in the world. Now, this is cardiovascular rounds. And so I'd just like to, if I can, this thing's not showing, but the mid-blue is cardiovascular disease. And you can see nearly everything's mid-blue. That's because globally over half of the deaths in the world are cardiovascular. But you can see hypertension is the leading risk for death, contributing to over 10 million deaths a year. The next thing I'm going to be talking about is environmental things at the end. And you can see it's now the air pollution is the second leading risk in this cut of data for death. Most of it cardiovascular, and it is related to small particles, which are from burning oil, gas, and coal. And then it supersedes tobacco. And then the next thing I'm going to talk about is salt, which you can see is within the dietary risks, again, almost superseding tobacco. Environmental issues like climate change, you can see non-optimal temperature is the 10th leading risk. And again, as cardiovascular people, you'll see the majority of climate change related deaths from temperature are cardiovascular. People don't do well in extreme heat in particular. Now, when we come to dietary risks, one can see that sodium is at the very top. Things that people get excited about, trans fats and sugary beverages, I've labeled, and I'd just like you to compare them to the impact of dietary salt. The Global Burden of Disease Study is not perfect. They made serious errors in their estimate of sodium, and it's about 1 million more deaths per year. And that relates to the fact that they have put very bad research into their estimates. And that's one of the other areas I'm trying to deal with in my retirement is really low quality research that undermines science and public health. This is a little bit on sodium and health. Yamanani tribe in Brazil have survived for a long, long time, hunter-gatherers, and they eat about 100 milligrams of sodium a day. Average world consumption, 4,000 milligrams a day. Long-term physiologic experiments over up to a couple of years have shown normal physiologic function in the range of about 150 to 300 milligrams per day. If you look at how we evolved, Paleolithic people, or if you ate natural food today, you would consume between 500 and 800 milligrams of sodium a day. 500 if you're vegan, 800 if you're eating lots of meat. The Australian and New Zealand government together put a report together, and they said adequate intake was somewhere in the range of 500 to 1,000 milligrams of sodium per day. As we start to get to research findings, there's an approximate linear relationship between blood pressure and sodium intake above 800 milligrams in randomized controlled trials. As we start to get over 1,000, we start to see increases in prevalence of hypertension in populations. Populations that eat under 1,000 milligrams per day are hunter-gatherers, and their hypertension prevalence approaches 0. Hypertension is not a normal human phenomena. It's something we've done to ourselves. Sorry, I'm just going to. Next, as we get to higher quality research, one study I was involved in was examining a meta-analysis of cohort studies that accurately assessed people's blood sodium intake. And that means they used multiple non-consecutive 24-hour urines. It showed a linear increase in cardiovascular disease between 2,000 and 6,000 milligrams per day. Now, it didn't show that it didn't decrease below 2,000 milligrams per day. That's where the data ran out. If we look at a meta-analysis of randomized controlled trials with post-trial follow-up, it showed a 26% reduction in cardiovascular disease between 3,600 milligrams per day down to 2,700 milligrams per day, with linearity down to 2,300 milligrams per day. And again, 2,300 milligrams per day did not define the lower limit of benefit. That's where the data ran out. Now, we can contrast this with very low quality research. And this is the PURE study, which has been highly publicized. They took a spot urine sample in the morning. So they asked people to pee once in the morning. Now, sodium intake varies meal to meal, day to day, and seasonally. When you eat sodium, nearly all of it's excreted within 6 hours. So there's no possible way that a short urine collection could reflect long-term sodium intake. But they use something called a Kawasaki equation. There's many similar equations which take age, gender, weight, creatinine, well-known cardiovascular risk factors, and these also interplay with sodium intake to calculate an estimate of 24-hour urine sodium. They, in their estimate, say the optimum sodium intake is between 3,000 and 5,000 milligrams per day. Now, we did an analysis of fatalities from eating sodium. Now, this is acute ingestion of sodium, not a good idea, largely in a fluid. In children, they can die if they eat 5,000 milligrams right away in a swallow. Adults, there's reported death from about 6,800 milligrams in fluid drinking. Now, Dan just showed you a meal with over that amount. Now, the fatalities are when you drink it rapidly, you overwhelm your sodium transporters, your sodium levels in blood go shooting up, and you don't look very good. In people here, some gray hairs, but in the emergency rooms, if you overdose, They used to give you a sodium gavage because it nauseates you and you vomit up. But they found out they were killing some people. And so they don't do that anymore. So this is another study I was involved in. In this study, in the close panel, we're looking at the TOHIP study, which measured blood sodium intake accurately with multiple non-consecutive 24-hour urines and the relationship with death. And you can see that approximately linear association. And I've sort of highlighted about 5,000 milligrams of sodium per day with the arrow. The data doesn't really curve at the top. You've run out of data. The confidence in whether it's a linear or a curve is not there. Now, if you look at the PURE study in the upper right corner, you can see this curvilinear J-shaped relationship. And so that contrasts with the linear relationship. The PURE study again used a spot urine with a Kawasaki equation. So what we did was we took the sodium concentration from the TOHIP study, again, very accurate sodium consumption, but we stuck it into the Kawasaki equation. And what the Kawasaki equation did was convert the TOHIP data into a J curve, showing that the Kawasaki equation changes the linear relationship with mortality into a J curve, i.e. it's something that shouldn't be done. I'm going to go quickly to punchlines. The World Health Organization estimates that reducing dietary sodium is one of the most effective mechanisms to improve population health. It is cost savings. They estimate in middle-income countries a cost saving or a return on investment of about 18 to 1. South Korea had a very successful intervention. Their cost savings was 70 to 1. Saved $70 for every $1 invested in sodium reduction. That was observational as opposed to estimation. If one was to optimize sodium intake and potassium intake, one could prevent about half of hypertension, perhaps substantially more, because most of the estimates are not from optimization, but just down to recommendations. That would prevent hypertension in about 750 million people globally. There is no high quality data to suggest you can add any amount of sodium to diets and it's safe. And so that's again something to just think about. The sodium controversy really relates to low quality research with flawed outcomes. Many of the scientists that continue to publish this work are aware of that, and I believe it's highly unethical, but we don't go after them. We recognize them for their research. Now, many of these people say it's too hard, it's not feasible to reduce dietary sodium. I know it's incredibly difficult for people to understand. There's very little sodium in food. We just add it. The complexity is add less, but that apparently is too difficult. So we're going to switch gears a bit. We'll talk about hypertension control. Increased blood pressure is the leading risk for death globally, over 10 million deaths a year. Now, Canada is the global standard for hypertension control, or at least was until this coming fall. We have one of the lowest prevalences of hypertension in the world, and we have the highest rate of hypertension control in the world of any sort of national figures. This was associated with a highly simplified primary care education program that started in about 2000 and ran until 2011 when the Harper government decided they didn't want to get involved in health anymore and stopped all its support. It also had a new hypertension organization that decided not to focus on hypertension control and also coincided with a reduction in hypertension drug patents, and so less funding from industry. Currently, hypertension control in Canada is decreasing, while in most other countries in the world, it is increasing. So our primacy in hypertension control is probably not even true now when we get our new data. In contrast to the Canadian program, the World Health Organization has established a highly systematic health services intervention for hypertension control that they're spreading globally. This is called WHO Hearts. It compares conventional mechanisms that we see in our practices, which are highly individualized care guided by evidence-based recommendations that are very, very difficult to implement in primary care and hence very infrequently followed. There's therapeutic inertia, which I like to call clinical chaos, and it results in low rates of screening, diagnosis, treatment, and control. And that's in contrast to Hearts, which is a highly systematic health services research approach. And it strongly resembles the design of clinical trials. So this is the approach. Very simple diagnostic and therapeutic protocol. A medication supply that is less expensive because the drugs are pre-specified. Bulk purchases markedly reduce the costs. It's enhanced by using combination drugs, which are lower cost if one considers also the prescription refills, and improves patient adherence. Community-based assessment of blood pressure and screening, team-based care, and then performance reporting at the clinician and clinic levels. And so you can identify the high flyers, the not so high flyers, and you can share information to enhance the low flying so they become high flying clinics and clinicians. The Pan American Health Organization, I'll call it PAHO for those of you who don't know. It's the WHO branch in the Americas. They are the leaders. They've got most countries in the Americas now with national hypertension control programs based on this. This is their whole guideline on one page. It starts with what equipment do you use? How do you measure blood pressure? Standardized cardiovascular assessment. What constitutes hypertension based on your cardiovascular risk? What are the targets that you're aiming for? Who needs aspirin? Who needs moderate or high dose statins? Exactly how do you manage the hypertension? What are the drugs? What are the drug doses? What are the intervals you see the patients at? So a really easy approach, one page that can be used in primary care. So Canada's been laggards. I've been really after both governmental as well as non-governmental organizations to adopt the Hearts program in Canada. But this year, Hypertension Canada has adopted this recommendation for primary care in Canada. Now, this may not seem innovative, but in the world, it's the only NGO that has done this. Everywhere else in the world, it's the governments that are leaders, but we can get to that a little bit later. But here you see a very simple diagnostic strategy, unique for Hearts. It incorporates ambulatory and home blood pressure measurement, and then a very, very simple therapeutic algorithm that can be followed, specifying intervals to see patients, what are the drugs and drug doses that should be prescribed. So about 2 or 3 years ago, the place where I'm actually a patient decided it wanted to improve hypertension control. And so they spent about 2 years developing their algorithms, their standardized approaches, monitoring and evaluation. And so they launched in 2024. They're still tweaking it, we'll say, but not a small clinic. It serves about 22,000 people in Northwest Calgary. So some punchlines. Individualized clinical approaches are more costly, less effective at achieving hypertension control versus the old way, step care in the 1960s and 70s, which just specified diuretics, sympatholytics, vasodilators, and the current approach of WHO Hearts. The Hearts approaches was innovated in the Kaiser Permanente, Northern California, and achieved 90% blood pressure control in their population. It's been duplicated in Colombia and in Chile. Canada was once a global leader in non-communicable disease prevention and control. We had a heart health strategy in the 1980s, highly innovative, and surveys. All that is gone. When I have talked to the Public Health Agency about hypertension and their involvement and can they get re-involved, they tell me hypertension is not a public health issue. It's the #1 risk for death in our country, but it's not infectious. We need some sort of a virus to cause hypertension before they'll pay attention. Nearly all the Pan American Health Organization countries have national hypertension control programs led by their public health institutions. And they also are countries like Canada where it's provincial or state responsibility, but the federal government is providing leadership and oversight. So this is something Canada does need, and it's usually a start, and you build in other NCD major risks into the algorithm once primary care is primed. So I'm just going to look at time. I'm doing semi-okay. So as I retired, as I said, I became more interested in environmental health. Currently, the triple planetary crisis of climate change, biodiversity loss, which means we're killing other things than us, and pollution are believed to be the greatest long-term threat to the health of humans and all other life forms on our planet. Currently, most of it in humans is cardiovascular. Now, I keep hearing in the news, Canada only contributes 2% to greenhouse gases. And so, it doesn't matter what we do. It doesn't matter. We're the 12th leading nation in terms of producing greenhouse gases. That's out of 200 countries, and we have a small population. In fact, if we break it down on a population basis, we're the 3rd leading country in the world on a per-person basis. Now, we're in Alberta, and so we can do better than the rest of the country. So we're the leading province. We even exceed Ontario in terms of our production of greenhouse gases. If you break it down on a per-person basis, it's sort of like football. Saskatchewan beats us. But anyway, we're the worst of the worst. Our contributions don't even consider the fact that when we export our oil and our gas and other people burn it, it's attributed to them, not to us. And so if we actually attributed the oil and gas that we produce and send elsewhere to us, we'd be like way over the top. Some of the most expensive climate disasters in the history of the country have been in the last 15 years, and they're right here. They're the flood, the hailstorms, the fires that we've had. And in fact, I think it was the year before last, I think it was 12 of the top 15 most polluted towns and cities in North America were right here in Alberta related to our forest fire smokes. So I note Steve Wilton's here, and Steve leads the Canadian Association of Physicians for the Environment Alberta branch. And so one of the things I thought I could do, I've been used to working in coalitions all my professional career. So I joined the Alberta Environment Network, which is a coalition of about 70 environmental organizations, and they agreed to let me form a health professional environmental group, which we call the Alberta Health Professionals for the Environment. Their members are there, and the vision was that the health sector could provide societal leadership in dealing with some of these issues. That's a picture from this year, by the way. So in coalitions, I usually follow a stepwise approach. And one is to educate the leadership. And we do this by doing calls to action, fact sheets, policy statements, and various different summaries for their membership. And so the executives and boards of these organizations have to read and approve it. And even if they reject it, they still have to read it and be aware of it. And so I think we had great success. We went to nearly every health organization in Alberta. They didn't all agree to join, but at least they were educated. And the second was to get these organizations to educate their membership. And this is by using their communication pathways and education pathways that are really well established for continuing health education. We ran into roadblocks. The organizations protected their membership from unsolicited educational material. And so most of them basically said, we'll send out stuff. If people are interested, then, and identify themselves, then you can send it to them. And so we have very select people in these organizations that are actually receiving our material. The next step was, assuming that we could actually get to the membership, that we would have a highly activated membership that could then interact with the public and educate the public. And there's a variety of mechanisms, traditional and social media, posters, handouts, videos, and clinics. Now, in Alberta and Canada, over 80% of the population visit their healthcare professional every year. And so you can actually get at most of the population on an annual basis through this mechanism. The fourth was to use this highly educated and empowered health sector to advocate for substantive public health policy. And so again, this is sort of failing as we go down through. And then the last is as a leading sector of the population, that we could engage other sectors of the population to support us and drive societal change. So it hasn't worked well. But what we have is some terms of reference, a fact sheet, call to action, what professional organizations do, so we can try to be internally consistent instead of just telling other people what to do and not following our own advice, what health professionals can do, what patients can do. And we've decided to actually do a couple of policy statements and looking for support. And one is to ban all coal mining and exploration. And the other is to transition and increase the capacity of the green energy grid. Why do something? Well, we're one of the most beautiful areas in the world, have amazing agriculture, very bountiful. People don't get it. We're the only feasible planet where we can live and other life forms can live. Now, Musk wants to send us to Mars, and even if he gets this space arc, look at Mars. you know, do you really want to move there? So all our future generations of life need clean air, water, land, and a safe climate. And we have to remember, we are the worst of the worst. How are we going to look to future generations? So punchlines. Has anyone here not experienced a severe climate event? I've experienced several. We're just at the start of the climate change disasters. That's one thing to remember. As we see our cities burning, the floods that are forcing communities to evacuate, hailstorms that are damaging, we're just at the very start. The costs of inaction are incredibly high. They say over 70% of businesses in Alberta have already suffered economic losses because of climate change. We're clearly lost and on the wrong path. We're trying to get more oil, gas, and coal out of the ground and burnt. The environmental sector, having been on the board of the Alberta Environment Network, does not have the credibility or the needed impact to drive societal change, especially when opposed by one of the most powerful commercial sectors in the world. The health sector is the most credible source of public information, and we really need to engage and provide that societal leadership in this effort, in my opinion. So these are just a couple of pictures I took last fall as I was out enjoying myself, and I would like other generations to be able to see this. Now, this is my last talk, and so I hope you'll forgive me, but I need to acknowledge a variety of people. Hude Khan, who really helped develop the surveillance system for hypertension control in Canada, was critical to that effort. But many friends and colleagues, many at the U of C, joined this effort for controlling hypertension, which was attributed to about saving, it was around 900,000 premature deaths in the country and 4.5 million hospitalizations through the enhanced control. The control rates went from 13% to 66% over about 6 years and are still sustained better than other countries in the world. George Fedor, who passed away in December, I was one of the very few physicians interested in population prevention and control of hypertension. I was very fortunate at Memorial to have him as a mentor. Don Mackay, a very, very close friend and colleague, but a variety of people at Memorial University who made me what I am, so to speak, and started my career off. Dick Winchelbaum, where he tried to train me in pharmacogenomics, but what he did was train me in research ethics and values and the need to be very rigorous and truthful in your research, something I think many others, particularly at McMaster University, might want to learn. Dr. Lackland, you know, and when I was president, Dr. Lackland was the vice president of the World Hypertension League. And we were very fortunate to have many, many good colleagues with us. The league was in trouble when we started. I wasn't sure it was going to survive my presidency, but now we have some of the top people in the world on the executive. Very, very influential league at this point in time. And they had very shared visions for population hypertension control and prevention, including reduction in dietary sodium. Pedro Ordonez from Cuba, one of the most dynamic individuals I've ever met. He's the reason that nearly every country in the Americas has a national hypertension control program. Branka Legetic, I chaired an expert and group for sodium reduction in the Americas in 2009. And by the time we were finished in 2014, the number of countries with programs went from 3 to 21. Still an effort that's ongoing. But some of them, such as Chile, Argentina, and Brazil, developed world-class sodium reduction programs. Hypertension Canada, and many, many people contributed to improving hypertension control rates in Canada. They really need to be acknowledged. There's too many. There was over 150 volunteers, healthcare professionals in that program, so I can't start to name them as much as I'd like to. Greg Taylor was, before Tammy, was our Canada's chief medical officer. He's one of my close friends. That was in the era where the Public Health Agency thought high blood pressure and hypertension was a public health issue. Leanne Vardy, another close friend there, and they really worked 7 days a week, long, long hours as your public health servants to try to enhance hypertension control in Canada. Mary LeBay, Hassan Hutchinson, many friends and colleagues at Health Canada that really worked incredibly hard to get a healthy food strategy for Canada and a national program for sodium reduction, including a national strategy. Tom Frieden, you saw his picture. I think he raised, I think it was $250 million US to work with the WHO on implementing hypertension control, salt reduction, trans fat, and pandemic preventiveness at Resolve to Save Lives. Andrew Morin, fantastic individual, was working on hypertension control. Sonia Angel is apparently very much like me, but an American doing similar things. Mark Joff, who really innovated the HEARTS program through Kaiser Permanente, Northern California, and many other people at Resolve to Save Lives. Taskeen Khan led the hypertension control programs for the WHO, including its World Global Hypertension Report and many of the programs at a global level. Godfrey was for sodium reduction at WHO, trying to get countries around the world engaged. And many, many other friends, colleagues who have worked with me and influenced my career and really made me what I am. But there's others, and I wasn't home very much during my career. I'm glad I didn't work till 80. But my wife, Jackie, my son, James, and daughter, Tina, who have really supported me through my career and still hang out with me. So I don't have a horse, so I'm not going to ride into the sunset. but I have a snowboard and a lot of hiking boots. And so I'm off into the Alberta sunsets. And thank you so much for tolerating this talk that I don't give anymore. Thank you.